Welcome to the Health Data Forum Global Hybrid Summit in Wales. We are thrilled to announce the launch of the Health Data Forum Global Hybrid Summit, a landmark event bringing together the brightest minds in health data from around the world. In today's rapidly evolving world, health data is more crucial than ever. This summit will explore how data can transform healthcare, improve patient outcomes, and drive medical innovation. Prepare for engaging keynotes, interactive workshops, and unparalleled networking opportunities. You'll gain insights into the latest trends, technologies, and ethical considerations in health data. This summit is for healthcare professionals, data scientists, researchers, policymakers, and anyone passionate about the future of health data. Whether you prefer to join us in person or virtually, our hybrid format ensures accessibility for everyone. Experience the summit from anywhere in the world. And for those joining us in person, prepare to be captivated by the beauty of Wales, our incredible host nation, offering a unique blend of history, culture, and natural splendor. Don't miss out on this unparalleled opportunity to be part of the future of health data. Register now to secure your spot. Thank you for considering the Health Data Forum Global Hybrid Summit. We can't wait to welcome you.
Greetings everyone, dear viewers. It's a great pleasure to be back here with all of you today. And again, with the Data First, AI Later initiative, we have the global movement. A pleasure to introduce our guest speaker today, Dr. Raunaq Pradhan. Is a product lead from the National Health Authority in India and is going to be interviewed with my dear co-host today and a recent newcomer to the movement, Dr. Padmavathi Roy, who is a physician who transitioned into healthcare IT with deep expertise in high AI ethics, cybersecurity, design thinking, HL7, FIRE, agile and safe practices. As a former chair of the Healthcare Forum, the Open Group, she has extensively led initiatives in intellectual property, patents, and responsible digital innovation. Dr. Padmavathi Roy champions the patient-centric and standards-based healthcare transformation. Welcome, everybody. Welcome, my co-host, and welcome, Dr. Raunaq Pradhan.
Thanks a lot, Paul. Thank you. So I would like to introduce Dr. Raunaq. Dr. Raunaq Pradhan has done his BTech in biomedical engineering from NIT Rourkela. And then he did a PhD in very young age in electronics engineering from NTU Singapore. Over the last 8+ years, he has worked across health education and public systems, building products that improve how people access and experience essential services. And he also has done that at Bajaj Finserv, Health, Indus Action, Intel Health, and through his own health tech startup, which is funded by BIRAC, Department of Biotechnology. He has led cross-functional teams, built 0 to 1 solutions in ambiguous settings, and collaborated with government stakeholders, vendors, and engineering, and teams to ship impact-driven products. He is especially curious about how we can shift from sick care to preventive, participatory health, and what it takes to make health and movement social, joyful, and habit forming. And also, how can we build large scale public systems for streamlining care delivery? He is also beginning to explore how data and AI can play a meaningful role in shaping the healthcare in the coming years, especially when we are uh, very fastly reaching towards the United Nations Sustainability Health Goals. Especially, I'm interested in Goal 3, health for everyone. So, welcome, Dr. Raunaq Pradhan, to our
Thank you.
podcast.
Thank you. Great to be here.
It's really, really great to have you here. And Padma, before you take the lead on the questions, I see, and Raunak, if I may ask you, because besides you being a strong data specialist and obviously contributing tremendously to what's now happening in the scenes in the digital health in India, but I see from your profile you are also a social innovator, a social entrepreneur, and you have founded
Right.
the Kel Club. Can you talk us a little bit about your experience with the Kel Club before
Sure.
we dive in the
Yeah. So
interview?
essentially, yeah. So as Dr. Padma pointed out, I've always been very interested in getting people to move, and like I've always been like you could say like very interested in sports right throughout my childhood. So because I've been interested in sports and I continue enjoying playing sports, I feel that everybody should have some movement in their life. There is one aspect of people who are more gym goers and who are like very focused on healthcare, health in general. But on the same time, like because all of us as kids we used to play, how can we bring some of that community aspect to our day-to-day lives today, where all of us are very busy? But at least in urban setups and tier two, tier three setups in India, everybody has had some exposure with sports growing up. So how can we bring some of that lifestyle from like from our childhood back to while we are growing up to ensure that there is some movement in our lives which
Yeah.
helps us stay healthier. So with Khelsla, what we were essentially trying to do is get people to play more sports. Started off with pickleball, but then eventually expanding to other sports as well. So the idea is to get build a community and get more people to play.
Fantastic, fantastic. But over to you, Padma, please. We have prepared a set of questions.
Yeah. Thanks a lot, Paul. So, Raunak, could you
Yeah.
walk us through the evolution of Ayushman Bharat Digital Mission and how do you think that it has transformed India's healthcare landscape from the fragmented medical records to a most federated and interoperable ecosystem?
Sure. So, so essentially, the crux of Ayushman Bharat Digital Mission, which is ABDM, the seeds of it were sown large, like long back before COVID came into picture. There are a lot of public health programs in India where ASHA workers are supposed to collect data. ASHA workers are the field people on ground who are responsible for delivery of healthcare at the last mile. So they were already collecting a lot of data in different shapes and forms. But as a part of the National Digital Health Blueprint, which was released in 2016, 2017 by NITI Aayog, one of
Mhm.
the focus areas was how do we make meaningful sense of all of this data, which is being collected by ASHA workers for public care
Yeah.
delivery, right?
Mm.
So, and while there were hospitals which were using some sort of EMR in their day-to-day practice to streamline operations, all of it was very distributed. There was
Mhm.
no correlation. If I, as a patient, walk into a government setup and then a private setup tomorrow, I had to carry my health records individually from one setup to the other, and
Yeah.
nobody was giving me access to the right set of data.
Mm.
And during COVID, we as a country in India realized that if we have to get everybody vaccinated, we need access of information very well documented at the last mile to ensure that each and every citizen in India is documented. So when COVID happened, we did a phenomenal job in terms of ensuring that each and every citizen in the country was documented and was vaccinated, and all of it came to fruition using Arogya Setu. So I think
Mm.
that is where the whole crux of ensuring that every healthcare provider has an identity, every healthcare individual has an identity, every individual which is getting healthcare has an identity, and every care provider also has an identity. So once the identity of everybody in this digital ecosystem is formed, post that, like whatever health records was getting generated would have to be digitized. So with digitization, there is a two-step goal. One is making people who are not digitizing today see the value of digitization. For people who are already digitizing or who were already digitizing, how can we make it simple for the patient by making these records interoperable? Because the Apollos and the Manipals
Yeah.
and the big hospitals were already digitizing to some extent, but the interoperability of records in terms of data transfer from one setup to the other when a referral happens was not happening. So that is what led to the evolution of Ayushman Bharat Digital Mission, where the goal was three-pronged. One, how can everybody have an identity? How can every healthcare provider start creating digital records? And three, from a citizen perspective, how can we define standards which can
Yeah.
help make this health data interoperable across systems?
Yeah. Exactly. So defining the standards, I think, more key into digitizing everything in the healthcare ecosystem, right? So even at the data first and AI next, defining the data standards is the key, and that is what the goal. And when you began actually working on the Ayushman Bharat Digital Mission, what was the core problem statement you were trying to solve? What were the problems statement that you have in hand? And I definitely know that the problem at that time, I know that at that time it is a multi-dimensional challenge everywhere, and there will citizen centric, and also from the provider centric, and also the policy perspective, and then government perspective, there are multi-dimensional problem. So what is that the most important problem statement that you have started prioritizing?
Okay, so in terms of the problem statement, so primarily, as you correctly pointed out, there are multiple stakeholders involved in the entire healthcare ecosystem, which is very different from the precedents that we had set with Aadhaar and UPI. So,
Mm,
as with any government scheme today, an Aadhaar is a mandatory requirement. So, it was similarly thought that for anybody to be identified in the healthcare ecosystem as a singular patient, the first step is ensuring that all the registries, everybody has an identity and the registries are in place. So a unified patient registry, a unified healthcare professional registry, a unified healthcare facility registry. So that was the base of which, like the base of the problem statement, where once everybody starts having a unique digital health identity is when we can start linking records, right? And the second, the problem statement, because everybody was already generating some sort of data, the goal was how do we make it interoperable? So one of the critical key points here is like implementation of fire servers, for example, or digitizing healthcare is an enormous activity, and not everybody has the capacity or the funds or the technical knowledge to be able to do it. So the one of the core problem statements was to focus on, like, let people generate data the way they are, let people focus on storing data the way they are. How
mm,
can we make it interoperable across systems by defining standards which only come into picture where interoperability is needed? It is
mhm.
not needed to store the data in file because that will require humongous cost. It will not make sense also for a country like India at this point to invest so much into health, for hospitals to spend so much into digitizing or changing their entire ecosystem, because that takes the focus from patient care to digitization.
Yeah.
So how do we keep citizen at the center of it and ensure that if a citizen needs access to the data, which is consent driven, how can we define standards which ensure that the data between the system A and system B can be understood by each
Okay. Yeah. So when you are actually designing the ABDM, and also the what, can you share the core architecture technology principles that underpin the ABDM, and how critical is the quality of data? Because you have just spoken about data, and which is disparate obviously into various systems or various places, and you wanted to use data as it is wherever it is, let it be, because we cannot disturb anything because in the patient centric care. So what is that core technology principles that you have considered uh, for the ABDM, and also what is the and how critical is the quality of data for making these principles effective in real world implementation?
Sure. So I think the core technology principles that underpin ABDM, one of which we already spoke about, is interoperability, which is to say that information across different systems must be understood by each other when
Mhm.
data is getting transferred. Right? So that is one. It is not about ensuring that everybody follows a certain protocol. Only when you're transferring data, how can you follow a certain standard, which will
Mhm.
ensure that the data is being understood by different systems. Second is federated architecture as compared to NHS in the UK, which for its public care delivery like ensures that all the data is segregated, is concentrated at one place. In India, storing so much of data, putting so much money into like storage costs, servers, and all of that is expensive, which is why we follow a federated architecture where we say whoever is the data creator will continue to store the data only when there is somebody who else who wants access to it can they should they share the data. So that is the second is federated architecture. The third is consent driven. So the by nature of whatever healthcare data is getting generated, the data creator has a copy to the sorry, has a access to a copy of the data, and whoever for it is generated for, which is the patient, has a copy of the data. So today in real world also, if we remove digitization, like if I go to a doctor, the doctor gives me a prescription. So the doctor has a copy of ensuring that in their system they have a copy of what the patient like was diagnosed with or what medicines have been given, and the patient gets a copy of it. So mimicking those real world principles, if I want to take the data from say Doctor A to Doctor B tomorrow, if I have been referred from Doctor A to Doctor B, the patient itself carries that file. So here also in the digital world, if we are sharing information across one system to the other, it has to be driven with user consent, where the
Mhm.
user defines how long is the data accessible for, who can access, what sort of data can they access. So these are the three core technology principles that underpin ABDM. And in terms of data quality, for any sort of analysis to be done in real world or for the government to identify where do we put vaccinations, where is more like incidents of like TB or tuberculosis or dengue or anything of that sort happening, ensuring that whatever data is getting captured is done in a structured manner is very important.
Yeah. So when you are talking about the federated architecture and also data stays with where it is originated, but just a patient will have in the real world, for example, patient go to hospital A, there some tests and some prescriptions are being given to this patient, and then patient goes to hospital B, then how a patient will be able to show hospital A's investigations or prescription of the doctor in the hospital B? Can you simplify this for the sake of the audience?
Yeah. So, if we talk about simplifying it, let us take a user journey, right? So, I am a patient. I walk into a hospital. The hospital is using, say, a hospital management information system, which is, say, provided by Practo, for example,
Mm.
right? So, whatever data, so if I do a consultation there, my patient details go into the system Practo, which is being used by hospital A. A digital record is generated and I am getting a copy of that digital record on my phone. Right. So now when I walk into hospital B, so when I walk into hospital A, like there is a digital health record which was created for Raunaq with a Aadhaar ID, which we call as Ayushman Bharat Health Account ID, that is generated for a patient, say patient Raunaq, and it has tagged and known to the system that the consent manager gateway in between essentially gets known that a digital health record for Raunaq was created. Now,
Mm-hmm.
if you go to hospital B is using a different platform. Say, for example, they're using Eka Care. Now, if hospital B is using Eka Care, the doctor there logs in, enters the Ayushman Bharat Health Account ID of Raunaq, and sends a consent request to Raunaq that I want to access your health records from hospital A. When the user sends a consent request, the consent request comes to a mobile application in the form of an SMS, also in the form of a mobile application notification also, that Dr. B from hospital, say B, who's using XYZ software, is wanting to get access to your health records. So the moment I provide a consent request as consent granted, I am giving access to the consent, I am giving access to my lab reports and prescriptions. These are the only two information. I'm not sharing anything else. So as the user, I can define how granular I want the data access to be given to. So once I give access that yes, my prescriptions and my lab reports can be shared to Dr. B, who is sitting out of hospital B. So the data gets shared from hospital A to hospital B directly. And the user also gets notified that their health and information has been shared. So that is how it works in real life.
So in this manner, our user, so benefits of this is user does not need to carry any physical records, and also the investigations or prescriptions provided by hospital A lies in the hospital A system, but only consent will be given to access. So nothing is even being stored on uh, Raunaq's mobile as well. It's
Correct.
just a link.
Yeah, and nothing is stored on the central server also. The central server consent framework, consent manager gateway only knows that a health record for Raunaq was created and
Yeah.
hospital will sent a consent request to Raunaq and Raunaq approved it. That's it.
Yeah. So, in again, a simple extension to the previous question, in a federated architecture like ABDM, we have spoken about quality of the data a lot, right? And what measures are being taken to ensure the consistency, standardization, and trustworthiness of data across such a large ecosystem, and especially in the context of data first and AI next perspective.
Yeah. So to ensure digitization and structured data getting captured, one of the so it is a very large problem and it will take a lot of time. But there are small experiments which the government is trying to do to understand what can help move the needle. So one of it is, for example, digital health incentive scheme, where any healthcare system which is digitizing a health record for a hospital, the government was giving incentives for every digital health record created in a structured manner. So that was one. Second, so this incentive was given to the healthcare provider also and to the software entity who was managing the system for them also. So incentive was given to both of them. Second, from a public health perspective, which is where the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana comes in, any sort of claim which the hospital is submitting on behalf of a patient, it had to ensure that it is providing that data in a structured format so that the claims can get auto adjudicated in the future. The patient can have to spend less and less time in the hospital. Uh, so there was incentive for the hospital to digitize so that the claims can get processed fast and they can get the money fast. From a private player ecosystem perspective, the private players were motivated or incentivized to ensure that they capture structured data, because only when they capture structured data is when they will be able to run analytics and be able to provide personalized recommendations to the user just by uploading PDFs and just by ensuring PDFs or hand-clicked images. Analysis on that becomes very difficult. So these are a few initiatives which ecosystem was essentially trying to ensure that more structured data gets generated.
Yeah. Okay. So, what is your since you are behind ABDM, and there are so much of roadmap ahead of us. So, what is your vision for AI enabled telemedicine in rural India, where I was actually doing some kind of analysis to see where we, as a country, India, with respect to doctor to patient ratio, and it is really alarming now. It's very high, like the gap between doctor to patient ratio, 1 in 11,000. So one doctor for 11,000 rural population. And how do you think that AI can help bridge this gap while maintaining the quality of the data and quality of the healthcare, and also improve the trust with the healthcare system?
Yeah. So I feel for telemedicine in rural India, I feel with more of like with more of technology coming in and with more providers in tier one India or outside being able to provide better care to the patients. So one definitely is reducing the load on doctors, where AI could essentially simple thing like a case history or a simple thing like a that you could say like the collection of what chief complaints you are having. So some sort of triaging could be significantly helpful for the patient A to understand if they have a certain set of symptoms, this is what it potentially may be, and they could take certain preventive actions for them to ensure that they are getting healthier or better. Second, it also reduces the load on the doctor or the treating physician, where the amount of time that they spend today in terms of interacting with the patient before figuring out what complaints they have or what could be some of the provisional diagnosis. I feel AI could also play a certain significant role there in terms of just reducing the time spent between a doctor and a patient. It definitely does not address the high doctor to patient ratio that we have, but it reduces the load on the
Yeah.
healthcare system in terms of ensuring that some of these patients who actually go to doctors for very routine checkups and things like that could be handled with some sort of triaging at a technology or at a system level, and that is where I feel in rural communities, ASHA workers play a very significant role because they already have that sense of empathy with the community. They already have good connect with the community. They already work with them for different health programs. So training them and using that ecosystem itself, where they're already used to collecting data and where there is already a sense of empathy, that ecosystem could be leveraged to reduce the load on doctors.
So, yeah, thanks for that. But is there any probability that ABDM will be having an extension into telemedicine as well in the future? More of telemedicine. I'm aware that some of the telemedicine platforms are available, but not much to cover the entire population of rural India.
Yeah, so we need to understand how ABDM is different from telemedicine applications. So the government of India, like CDAC, has its own telemedicine platform. There are NGOs who are building their own telemedicine platforms. What ABDM is just helping them is to structure and streamline how data needs to be collected and how data needs to be collected. Right? It is helping them simplify the time, reduce the time that they need to build healthcare applications, but ABDM is more responsible for just building the framework and defining the framework. The applications will still need to be built by government entities, by NGOs, by
Mhm.
private players who can leverage what ABDM is providing to build applications faster. Yeah, so that is
Yeah.
the crux of it. That ABDM will not solve for remote healthcare. They will just help define standards and protocols, which will make it easier for people wanting to get into that space to do it
Yeah,
faster.
that's good. And we have just emerged from the global health crisis, which is COVID-19, and we know what is the effect it has created on the world healthcare as well. So, and now AI is beginning to reshaping many industries, and healthcare also one among them. How do we urgently address the growing global physician shortage, and what role can digital infrastructures like ABDM play in solving this challenge?
Okay. So I think so different countries will have different contexts. For example, NHS has done a great job at digitization and ensuring that good data gets collected, and for them to use that data to solve public healthcare challenges. In India, it is a bit of a different structure where because predominant of our healthcare is private
Hmm.
driven, like ensuring that the private healthcare system also gets digitized is important for interoperability and sharing of data to happen. So I feel different countries will have different sort of approaches. What I definitely see happening is, like say for example, the medical tourism industry to go up. There are countries like Africa which don't have access to a lot of healthcare services today. Like them leveraging something which India is providing in terms of telemedicine and in terms of availability of doctors, that collaboration between countries happening where there is less access to healthcare. So technology, I feel, would play a very significant role there. in terms of connecting patients in Africa to patients in India, in terms of helping them digitize, in terms of the DPI movement. There's already quite a bit of work in the digital public infrastructure movement going to countries where there is need for digitization. So I see more of these collaborations happening at the technology and the platform level. However, the local context of what healthcare is will continue to stay very local and relevant to what the geography is. And every country will have its own approach of solving for it. But at a macro level, I think sharing of data, sharing of best practices, these are things which can help the global community as a whole.
Yeah, exactly. I agree with the point where Africa and some of the other areas where healthcare is not approachable. Recently, I have written an article as well about Fellow Paper Train, which provides in a train. So, in such kind of remote areas, definitely telehealth is going to play a major role. And when you rightly mentioned technology, with technology we can actually create such kind of facilities into the world healthcare scenario. And with that, do you agree with the idea that the future of healthcare is not about humans versus machines, definitely, but both, but about humans working with machines, uh, like AI. How prepared is the Ministry of Health in India to adopt and scale AI enabled healthcare services responsibly?
Yeah, so I think the government is already doing quite a bit of work. So there's this organization called DIRA, which is Department of Biotechnology, which funds a lot of deep tech innovations happening in the country in terms of diagnosis, in terms of early prevention, in terms of cure as well. So I think that is one trajectory where deep tech innovations are continued to get supported by the Department of Biotechnology. On the other side, there is the digital health side of things, which have to work in tandem with whatever devices exist to collect the right set of data. So I think that is the second trajectory where a lot of private innovators are also now being encouraged to ensure to develop new tools, to develop faster methods of digitization, to enable simpler methods of digitization. So that is the second trajectory. And then what brings all of it together is good data, right?
Yeah,
So once we have enough funding or enough support on the deep tech side, then we have on the deep tech slash devices side, then we have enough support on the digitization side via ABDM. And on the third side becomes like enabling organizations or NGOs to collect the right set of data and ensuring that whatever data we are collecting is collected in the right manner. I think AI is still some time away, but what the government is definitely trying to do is define patterns for how data needs to be collected and what you can do with the data, which is where the consent framework also comes in, where using the data in the right way is something which the government is now trying to look at to see that
mhm,
now we have so much data. How do we look at data the right way? How do we ensure who have access to the right set of data? So there are India AI Mission is leading that initiative where they're coming up with white papers on what you can do with the data and what you cannot, so that the data that we are generating is not misused in the wrong manner.
yeah. So how do you like when again extension of that question? We have various systems even in India. Many it's healthcare is everywhere, and also there are private hospitals or private organizations providing healthcare, and they have their own systems. uh,
Right.
and government is also having ABDM and other Ayushman Bharat Digital Mission, and we have some data from the government perspective also. So how does all this data is considered for looking into that quality and things like that for future utilization?
Yeah, so I think what the government is doing, or what the ecosystem is also doing, is defining those principles so that data is not misused.
Hmm.
So coming up with regulations, coming up with principles which say this is how the data can be consumed, because like there's no control on who's generating what sort of data.
Hmm.
And in India, for lack of a better word, there's no central regulator as such, right?
Yeah.
So that makes it a bit challenging, But I think the larger mission of ensuring that India becomes a more healthier nation and everybody has access to the right healthcare, and everybody has access to the right healthcare, and also at the same time healthcare which makes them better in terms of the correct diagnosis being evidence-based health as we talk about. So I think as a country, while we are trying to move towards evidence-based health, it is important that all the stakeholders are aligned towards evidence-based health as a mission, which will ensure as a result that all the data that is getting collected is collected in the right manner and is getting used in the right manner.
Yeah. And my final question for today's interview is privacy and information security are of utmost importance anywhere, especially in the healthcare, and especially when we talk about the frameworks like HIPAA and GDPR. And how does ABDM address these privacy and security concerns,
Yeah.
particularly around patient consent, data encryption, and protection? You just spoke about misuse, protection against misuse, while still enabling interoperability at scale.
Yeah. So I think what ABDM does is any application which is getting ABDM certified at this point of time has to follow certain protocols, which is in terms of like VAPT or any sort of certification, security certifications defined by ISO, which are
Mhm.
mandated for any application handling the data. Right?
Okay.
So because it is baked into ABDM certification as a process, by default, ABDM ensures that all the consent laws are followed, data is not getting leaked. So as a
Okay.
part of the certification process itself, any entity which is trying to like get ABDM certified or handle medical data will ensure that the basic minimum requirements are getting certified. So
Mhm.
that is how it is ensuring that like there's no misuse of data. And the certification also needs to get renewed over a period of time.
Yeah. Yeah. Also, when previously you spoke about the regulations, we don't have data regulations. So,
Right. I
what
think
kind of proposals that
the
you?
the the Data Security Act is still in progress. I think it's a matter of time before that becomes a reality. So once that comes into picture, everybody will be required to conform to that if they're
Yeah.
building any digital system. I think with that regulation becoming an act, slowly we'll move towards that direction.
Okay. And also you mentioned about ABDM certification. So what does it mean? Does the all these private entities who have their own systems like EHR, EMRs need to
Mhm.
get certified, have a ABDM certification for the quality or the uh,
Correct, correct. At this point of time, it's not mandated,
uh-huh.
but over a period of time, I think it will people will start conforming to the standard. So
Yeah.
there's a process that people need to follow, which they can find out on ebdm.gov.in in terms of
Mhm.
how do you get your application certified.
Yeah. That's wonderful. Thank you, Dr. Pradhan, for
Thank
sharing
you.
your insights and practical experiences with us. And your work on fire and ABDM is inspiring and
Thank you so
sets a
much.
strong example of what it means to build ethical, scalable, and interoperable healthcare system.
Thank you. Lovely talking to you.
Thanks a lot. Thank you.
Thank you.
And to our audience, if you want to explore further, please check the link shared by Dr. Pradhan in the description. So I would request you to share anything which our viewers can access. And don't forget to like, share, and subscribe our channel at Data First and AI Next.
Thank you.
Thanks a lot. Thanks a lot.
Yes. Thank you. Thank you so much. Thank you so much, Padma, for these wonderful interviews, Dr. Ronak. It's really amazing insights we get here today from you. Thank you so much, dear viewers, for staying with us in this another episode of Data First AI Later interview. This time with Dr. Raunaq Pradhan, product lead from National Health Authority India.
Thank
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 you.
you
you,
so
everyone.
much, and stay
Have a
tuned.
wonderful rest of the day, all of you.
Yeah.
Cheers.
Everybody's looking for a healthcare system they can trust. In the age of AI, transparency and ethical data practices are revolutionizing healthcare. By ensuring that data is handled with care, we build trust among patients, healthcare professionals, and stakeholders. Why does this matter? Ethical AI ensures that every decision made
is aligned with human values, providing accountability and eliminating bias. This means better outcomes for everyone involved. But it's not just about technology, it's about trust. When patients know their data is safe and used ethically, they feel more confident and engaged in their healthcare journey. Let's embrace transparency and ethical data practices, because a trusted healthcare system is a better healthcare system. Transforming healthcare, one ethical step at a time.